Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I'd like to welcome you back to another journal club. Thank you for joining us, and I want to always thank ESGO and IGCS for their support of our journal club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's journal club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording, so we ask that everyone please keep your microphones muted so that everyone can hear the presentations. And if you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. Definitely want to encourage questions from the audience. You may submit your questions via the chat function in today's session. So with that being said, I want to proceed with the introduction. This month's lead article is titled Checkpoint Inhibitor Re-Challenge in Advanced Endometrial Cancer, Revisiting the Immune Landscape Beyond First-Line Therapy. This article is authored by a number of authors in the field, but today we're going to be speaking to Vivak Potter and Brian Slomovitz, both at Mount Sinai Medical Center in the Division of Gynecological Oncology in the Department of Obstetrics and Gynecology in Miami Beach, Florida. Of course, we're all jealous and we wish we would be there in Miami Beach. So I want to again thank you both for joining us as discussants in the Journal Club. I want to welcome you. Vivek and Brian, thank you for always being available through the podcast and now the Journal Club. I'll hand it over to you for a brief summary of the article and presentation, and then we will get started with our questions. So thank you once again.
Yeah, first of all, Pedro, let me just say thank you very much for having us. I say this seriously, you really redefined the journal. And I said this to you jokingly, you've made the educational world a smaller place, which is important because I think we need this. We don't need to, we need to learn globally about the differences in what we're doing. And personally, for me, thanks for the support that you've given me over many, many, many years. I'm not going to tell people how old you are, but you look a lot younger than what you are. So thank you for that.
Thank you, Brian.
and I'm going to, I want to acknowledge we have a research fellow here at Mount Sinai Medical Center in Miami Beach, Vivak Potter. Vivek's been with us for over a year. With his support, I don't know if I've ever had a year more prolific than I've had this past year. So again, thank you for making this a comfortable place for fellows to present, right? I mean, that's important. It's just not a chance for some older people like me, not you, me to present. So thank you for that. And Vivek, I'm going to turn it over to you, but I wanted to give that introduction because we can't do what we do without our learners and turning our learners into seasoned researchers. So thank you.
Thank you so much, Brian.
So thank you, Dr. Pedro and Dr. Slomovitz. So good morning and good evening, everyone, and good afternoon, everyone, wherever you are. So I am Vivak Poddar, and today I'm going to present our work on checkpoint inhibitor re-challenge in advanced endometrial cancer, revisiting the immune landscape beyond first-line therapy. So before I begin, I would like to thank again sincerely to Dr. Pedro and the entire editorial team for selecting our article as a lead article and also inviting us to present the journal club. And I would also like to thank the author team and our supervising and corresponding author, Dr. Slomovitz, under whom I have been the privilege of working as a research fellow. So this article in this work is really important and timely because a lot of patients with cancers are getting ICI therapy and there is an increasing chance of ICI relapses. So clinicians are in a dilemma and they don't have a guidance as to how to treat once the patient progresses on ICI therapy. So the first slide will talk about the clinical context and the clinical gap and the evidence gap that has led to the article in the paper that has led to this work. So can you go to the next slide? So these are the author team for this article, and so I'm going to talk about the clinical context and the unmet need in this area. So endometrial cancer is rapidly increasing all over the world, and it is one of the most common cancers where ICIs are commonly used. And despite the initial responses are very impressive, almost 10 to 40% of the frontline trials have shown the patients has early progression, and even many of the other patients will eventually progress into will eventually progress. So it means we will have a lot of patient population who will be relapsed. And interestingly, in the trial, which is Ruby trial, had a 35% of the patients who were actually treated off protocol with the ICI re-challenge. So it indicates the practice is moving faster than the data. And also there is a clinical gap, which is the clinicians are thinking, if the patient progresses, what's next? How to treat them? But unfortunately, there are no prospective trials to guide the ICI re-challenge. So there is a key evidence gap in this area, which is how to select the right patients and what could be the timing of the patients to treat and whether ICI interval matters. And even if we can strategize the patients with combination regimens, that is going to be discussed in the next few slides. So before I go and talk about the current evidences and ongoing studies, I would like to talk about the biological rationale for resistance and also the re-challenge. The first question is how tumors develop resistance to ICIs. So there are three common mechanisms we found that predispose patients to ICI resistance. One is the loss of antigen presentation, notably via mutations in the B2M, JAK1/2, and which basically means the immune system cannot see the tumor, they cannot visualize the tumor, so they cannot act upon. The second mechanism is T cell exhaustion. The chronic exposure to checkpoint blockade causes the T cell to be exhausted, and even though the T cells are there, but it is dysfunctional. And the third mechanism is immunosuppressive tumor microenvironment, mostly via VEGF, which is vascular endothelial growth factors, the myeloid-derived suppressor cells, and regulatory T cells. That makes the tumor microenvironment immunosuppressive, so the immunotherapies cannot work on the tumor. And the interesting part of the biological rationale is, even though dMMR tumors are supposed to be more responsive to ICI therapies, even in them there is a specific group which is called MLH1 methylated dMMR tumors, which are less immunogenic than the Lynch-associated tumors. Because of this less immunogenicity, the tumors are producing less new antigens that limits the effective T cell recognition and also the ICI response. That is one of the reasons, this MLH1 methylated tumors are less responsive to ICI. Now the question is, does molecular profiling guide the re-challenge strategy? Practically, in clinically, there is a limited validated biomarkers that can guide the re-challenge strategies, but in the clinical trial setting and in the theoretical perspective, it can identify the mechanism of resistance. For example, if we can detect the mutations in the B2M and JAK1/2, that can help us understand the mechanisms of resistance. And also, if we know the specific biomarkers that is actually causing this resistance, we can support the personalized re-challenge strategies, or even we can re-challenge and also add a new combination of therapy that I'm going to discuss in the next slide. So that is going to help a better response once the ICI fails to work. And the other thing is, now the question is how re-challenge is going to help with the once a patient progresses, how re-challenge is going to help. It basically restores the anti-tumor T cell activity by the very mechanisms that I have talked about, which is the loss of antigen presentation, the other is T cell exhaustion, and the immunosuppressive TME. So we can actually overcome all this resistance possibly by rational combinations, for example, dual checkpoint blockade or maybe VEGF inhibition, which is actually going to normalize the vasculature and reduce number of myeloid-derived suppressor cells and regulatory T cells. That is basically reducing the immunosuppressive tumor microenvironment that is more favorable for the drugs to work. And the other is PARP inhibitors that is going to help patients also with like they produce the DNA damage, so there will be more neoantigens, so the ICI can work more on these cancers. So this is about the biological rationale for resistance and re-challenge. So now I'm going to talk about the ongoing evidence strategy. Now I'm going to talk about the clinical evidence, which we already have, and some of our directions, that is how we can re-challenge the patients with ICI. So there are few trials, there are some few retrospective studies that are there, which showed 50 to 75% response in selected dMMR patients. For example, in pembrolizumab plus lenvatinib, in a study which investigated pembro plus lenvatinib combination therapy, they found clinical activity once the anti-PD-1 failure. And similarly, cabozantinib plus nivolumab offers durable benefit for more than 20 months, including in even microsatellite stable tumors. So this is about some of the retrospective studies. And there are some studies which are ongoing, which is the combination strategies once the ICI fails. One is NRG GOI-025, where nivolumab, ipilimumab was investigated after an ICI-free interval. So because once the ICI-free intervals are there, so we have a chance to revive the exhausted T cells. The other one combination is anti-VEGF combinations that may remodel the tumor microenvironment, as you have told, and that it can normalize the vasculature and reduce conduction of the regulatory T cells and also the PDSRs. So the other one is PARP inhibitor combinations. They are already in trials in different cancers also, mostly in melanoma and non-small cell lung cancer, but there are a handful of studies which are actually investigated in endometrial cancers. The other group of drugs which are really important and interesting, I would like to emphasize, is Warren helicase inhibitors, which actually exploits the synthetic lethality of the tumor vulnerability in microsatellite stable, microsatellite MSI high and dMMR tumors. We have some non-immune mediated killing mechanisms, which is actually Warren helicase inhibitors that produces a replication stress in the cell, and that induces the apoptosis of the cell. So that is a very interesting mechanisms of killing the tumor cell that is mostly in the preclinical trials, and notably HR0761 and NTX452, which has shown durable regression in preclinical models. And this drug has been investigated as a potential synergy with immune checkpoint inhibitors or chemotherapy in dMMR endometrial cancers. So these are the trials we have in place and some evidences that is suggesting and giving us a direction. Now the challenge is we have to define the optimal candidates, possibly via molecular immune profiling and some integrating the next generation checkpoints like LAG3, TIGIT once the ICI fails. So we have those options. And also we need some more prospective trials in endometrial cancer where we are investigating Warren helicase inhibitors with ICI. So possibly this will explore and give us more direction on the ICI challenge strategies. So yeah, that is all about this challenge strategies. We have some new studies that is already published in the article, and we can see all the ongoing studies in other cancers that can potentially be integrated and used in repurposed in endometrial cancers in future.
All right, Vivek, thank you very, very much for that presentation. And we'd like to actually now get on to some of the questions that we have from our fellows. And then again, of course, obviously, we encourage everyone who has joined us for the Journal Club to submit your questions through the chat. So we'll start with Mathilde Del from Toulouse, France.
Thank you very much for your presentation, Vivek. Molecular status alone does not appear to be predictive of the response of a checkpoint inhibitor in advanced endometrial cancer. Does molecular classification still have a role in guiding management, or should it be replaced by the assessment of tumor burden?
Yeah. So I think molecular classification and tumor burden actually answer two different clinical questions. One doesn't replace the other, they work together. For example, molecular status remains the primary gatekeeper for immunotherapy. For example, in DMMR or MSI high tumors, respond is extremely well to single agent PD-1 inhibitors, while proficient MMR tumors usually don't, so we rely on combinations like pembro and lenvatinib. Even with DMMR, we have already discussed that MLH1 methylated DMMRs is less immunogenic than Lynch-associated tumors, which also explains that why they are less responsive to immunotherapy. So molecular subtype tells us who is biologically likely to benefit, and tumor burden tells us something different. It doesn't change the biology, it affects how we manage the patient. For example, high volume, fast growing disease may push us toward combination therapy or close monitoring. And low volume indolent disease, especially in DMMR tumors, might be a good setting for single agent immunotherapy. So in a nutshell, molecular class tells me which treatment makes biological sense, and tumor burden tells me how aggressive I need to be with that treatment. So maybe both are complementary. This is my, yeah.
Oh, sorry. No, I think that's a great answer. I think it's a great question too. Now remember, we changed the world in how the language of endometrial cancers. We used to refer to these as type 1 and type 2 cancers, based on great work really led by the TCGA in the early, I think 2012 or 2013. Doug Levine led that when he was at Sloan Kettering, and then based on some of the PROMISE data, no longer is it type 1 or type 2. It's really the 4 classifications. Okay, and the 4 classifications, as you know: POLE mutation, DMMR, MSI high. Those are the hot tumors, right? And that's what Vivek was alluding to, is maybe more amenable to post-IO after IO therapy. And then the colder tumors, what we call the PMMRs, are the NSMP, the no specific molecular profile, and the P53 mutated type. Not only are they distinguished molecularly, but more important, or equally as important, they're distinguished in prognosis, and they're going to drive treatment decisions. So when you talk about tumor burden itself, I think you're referring to the volume of tumor. I think that's important, when we're talking about adjuvant therapy versus neoadjuvant therapy, which patients get which. But I think what supersedes that is the molecular profiling. I've seen patients with ton of tumor that are DMMR have the tumor melt away with IO therapy, while a lot of us have seen that in the clinic. Now, another term when we talk about tumor burden, we talk about tumor mutational burden. That has a tumor agnostic indication across the board, and that is also very, very responsive to IO therapy. But overall, it's a great question, and I just want to add that. Thank you.
Great. Thank you, Brian. We have a question, and Brian, maybe you can answer this. Ferda Verit from Istanbul, and asking, what is your opinion about WES aneuploidy scores in endometrial cancer and immunotherapy resistance?
Yeah, great question. I think that there was a lot of attention that was brought to that at the ESMO meeting, where they talked about exactly that, the aneuploidy score and the response, or I should say lack of response to therapy. It makes sense, and I don't have the chart. It makes sense. Anything that we could do to delineate the responses, and then there's that 5 to 10% that don't respond, and it seems like the aneuploidy score high sort of helps to identify that. But these were all secondary exploratory endpoints of these studies. I think as we move forward, we should look at that in more of a prospective way, which would be nice. And similarly, looking at other markers, we should look at ctDNA in a prospective way, because we need to do two things. We need to figure out who's going to respond. But then in those patients like this who are getting adjuvant therapy, we need to know how long should we keep the adjuvant therapy for. The last thing we want to do, the first rule of medicine is to do no harm. The second rule is to do good. So not only do we want to do good for our patients, but we don't want to expose them to unneeded side effects if the drug's not going to work. But that's new information that just came out of Berlin a couple weeks back.
Excellent. So we'll go on to the next question. It's also from Matilde. Matilde, please proceed.
Yes, it's in a question coming from Carlota, but she's not here today. Among patients who relapse after a long platinum-free interval, which factor do you consider most decisive when choosing between an immunotherapy rechallenge and standard chemotherapy for recurrent endometrial cancer?
Yeah, so I can partially respond to this question. So when someone relapses after a long platinum-free interval, we can focus on several things between deciding ICID challenge versus chemotherapy. So one is the molecular profile of the tumor. So DMMR, as I have talked, the DMMR MSI high tumors, especially the Lynch-associated ones, may be the best candidate for immunotherapy rechallenge, and also the prior ICI experience. If they have previously deep durable response with a manageable toxicity, rechallenge may be reasonable. But if they have a primary resistance or severe immune-related adverse events, then I think we may need to reconsider about the rechallenge. The other thing is the current disease. Yeah.
Oh no, sorry. I think that's spot on. I think again, it's a great question. Let me tell you. So you brought up the term platinum-free interval. All right, that never existed in endometrial cancer. The FDA created that definition. When we talk about platinum sensitivity and platinum-free interval, we always sort of think about ovarian cancer, not necessarily endometrial cancer, but with drug approvals and drug development, we're sort of incorporating that more and more. What is defined as the platinum-free interval that we should re-challenge with, let's say, carboplatin paclitaxel first? The answer is we made it up. Ruby was 6 months. DuoE was 12 months. I can't even tell you that two different groups made it up because as a side note, the GOG developed both of those stories in the same day on a December afternoon at Newark Airport. In the morning, we met with one company. In the afternoon, we met with another company, and we just made that up, and we were lucky, right? But as we talk about now, drug development in the second line, for the most part, if the patient has been 12 months away from carboplatin paclitaxel for second-line studies, we're required to retreat with carboplatin paclitaxel because there's activity and because we don't want carboplatin paclitaxel, follow me, to be in the control arm of these studies we're developing. Vivek was right. DMMR likely to consider re-challenging. If they didn't get an IO in the first line, obviously there's room there for either the Ruby regimen or the GY018 Keynote 868 regimen or even the DuoE regimen. But a final note on this. Remember the LEAP study, carboplatin paclitaxel versus lenvatinib pembrolizumab in the first line, was a negative trial. But in a subset analysis, those patients that had prior adjuvant therapy, sort of what you're describing here, there was a significant difference. So maybe the second line there, retreat with carboplatin paclitaxel, IO therapy if they haven't received it, maybe non-chemotherapy, and of course, beyond the scope of this talk, and we have a lot, there could be a lot to talk about, the plethora of ADCs that are under clinical and development, and even the ADCs with FDA approval, the trastuzumab deruxtecan for the HER2 positive patients. But a lot of information there, and hope you caught on to some of that.
Excellent. So, Brian, lots of questions on the chat, and I'll turn to Priyanka Singh. Should TMB testing be done in P53 wild-type tumors with MSI stable, proficient MMR?
It's interesting. So that classification, I don't do poly testing in my institution, and until poly testing changes what we do, till poly studies changes what we do, we send it out. So I don't believe in that. But that molecular profile that you just described, in my mind, is leaning towards a poly. High tumor mutational burdens. We need poly. They're hypermutated. And what people forget, polymutated tumors are pMMR. They are microsatellite stable. So that would lead you toward that. The answer is yes, I would rely on that testing. The answer is if it's high TMB in the second line, you could consider single agent immunotherapy. Because we talked about earlier cold and hot. Those are cold according to molecular characteristics, but TMB itself in the US has an FDA approval in a tumor agnostic setting.
Excellent. So we'll turn over to Itzi Villagra, who's going to ask the next two questions.
Thank you for your presentation. Your review points out that a surprising number of patients in the RUBY trial went on to receive off-protocol immunotherapy, which really highlights how quickly practice can outpace evidence. But access isn't uniform. What's possible in a US private system might be far harder to navigate in publicly funded systems where reimbursement demands stronger data. How do you think clinicians should approach this gray zone, and how much does the country or healthcare system shape those decisions?
Yeah, so great question. This is an international forum, and you're spot on. I mean, the treatments that we can offer our patients in the US are oftentimes a longer list than globally, because once it's FDA approved, where it's almost like a negotiation with insurance companies in order to get it or not. The problem is it happens. So we have to understand that. The problem is it happens sometimes outside of FDA approvals. So right now we're collecting some anecdotal data, just almost case series as was described earlier. I think we need to do more and more prospective of studies evaluating it. But to answer the most important question, what we do in the US, it can't be done globally. We've learned that, the use of some of these drugs. That being said, sometimes globally they're available to get drugs, and in the US they don't. Up until recently, the DuoE regimen with olaparib wasn't approved, but it was approved somewhere globally. It's still not approved, but it has a NCCN type 2B designation, which will still be hard to get, but it can get globally. So great question, important for this international forum, and it's something that we need to continue to push for, the global approvals of some of these drugs and not overusing drugs that aren't approved.
Excellent point, Brian, and we may come back to that in a few minutes. Itzi, I think you have another question as well.
Yes, something a little bit out of context, but are there any strategies to identify early progressors on frontline immunotherapy? Since even in mismatch repair deficient, there are a substantial percentage of these patients.
Yeah, I think good question, spot on. I think that you're right, about 10% of the DMMRs fail to immunotherapy. I will call out, if you remember this Kaplan-Meier curves for RUBY, GY018, and even DuoE, during the chemotherapy, the curves don't separate. They only separate in the maintenance phase. Specifically, to answer your question, we do routine screening on all of our patients in the first 6 cycles. Usually we give them 3 cycles, repeat imaging to see if it's responding or not, and then we keep going. Maybe that aneuploidy score, as asked about earlier, may help us out. But outside of that, the future of ctDNA is bright. Shannon Weston presented ctDNA studies from DuoE, and it was pretty intuitive. Patients with ctDNA positive did worse than ctDNA negative. So that might be another way that we may monitor these diseases as we move forward and determine when she would stop therapy outside of traditional radiologic imaging.
Brian, as a follow-up to that, in the practice, we're actually seeing patients either coming to us or even from our medical oncology colleagues now kind of like routinely getting ctDNA as like surveillance after completion of therapy. Thoughts on that?
Yeah, it happens. I mean, I could tell you, I'd see about in a month, probably 4 or 5 patients that come to me as a second or third opinion, not only endometrial cancer, but ovarian and other cancers, ctDNA positive, negative PET scan. What do you do with it? I could tell you that this is evolving constantly. I used to ignore ctDNA findings. You can't ignore it anymore. Once they come with those findings, I don't treat them if there's PET scan negative, but I'll watch them more closely. I'm anxious to put them on trial, and I'm anxious to see if there is any practice-changing trials to incorporate that into our trials. But I think that's the best we could say at this point. And you're right, Pedro, we see it a lot. And we don't order it, but it's frustrating because we can't tell the patients ignore the results because, it's their lives on the line. So
Excellent. Next, we'll go to University Hospital Münster in Germany, Masha Pervin.
Hi, thank you so much for this nice talk and very good article. What do you think warrants or doesn't warrant a change of immune checkpoint inhibitor at re-challenge? And would chemotherapy after progression on immune checkpoint inhibitors for limited cycles not necessitate release of new or current neoantigens, which in turn would make re-challenge to checkpoint inhibitors more effective?
yeah, no, tough question, but I'm not afraid of tough questions, and a great question.
Masha, he can take it. So great question.
Bring it on. That's all you got? No, I'm just kidding.
That's all you got.
So I think it's a class effect, right? Meaning if you're on pembrolizumab, I don't think that if you changed it later on to dostarlimab, durvalumab, or atezolizumab, it's going to be different. I do believe that I'm not certain of this, but I think PD-1s are more active than PD-L1s. If you look at the data and in your mind, look at it from a cross-trial comparison data, the Pembro 0.30, DMMR, dostarlimab 0.28, and the others are a little higher. Maybe it's PD-L1s, maybe it's something different. Remember, the ATTEND trial had 30% Asian population, which may not be as responsive to immunotherapies. So that's the first question. Regarding the timing and should be sequential or concurrent regarding neoantigen release and maybe making IO more effective after induction chemotherapy, as you know, in the IO after IO setting. Great question. We don't know yet. I think it's important to continue to do those studies. That'll be sort of like translational exploratory studies that are going to require additional biopsies, where those studies, as you know, Masha, you're nodding your heads, yes, those are tough to do because patients don't want more and more needle sticks and biopsies and things like that. But as we move forward, we'll see. And you're right. If we see a higher response, then that may work. How about also, I mean, the other thing you didn't talk about is not only IO after IO, but in that sense, IO and then hormonal therapy and then second-line chemo and then ADC and then maybe going back to IO. Maybe that's going to be the boost that we need for the neoantigen burden. But you got to do better than that.
Thank you so much, Brian and Masha. And we'll turn it over to Matteo Lovero in Policlinico Gemelli.
Thank you very much. So my question is, when is immunotherapy re-exposure justified in patients with prior toxicities? Given the paucity of evidence, what thresholds would you apply, and should the decision just be justified by the expected treatment benefit or also by toxicity, previous toxicities?
Yeah, great. That's really an important question because we're talking a lot about efficacy, but we can't ignore toxicity, right? And a lot of times, toxicities could be life-threatening and game-changing, or toxicities could be there that we could have managed, and maybe the doctor who's referring them to you didn't, I don't want to say didn't manage, weren't as aggressive with a mitigation strategy, and you took away a possibly good drug when you didn't need to. The perfect example of that, and follow me on this, the perfect example, when you give pembro and lenvatinib, and as you know, while LEAP's negative, Keynote 775, led by Vicky Macker at Sloan, was a game-changing trial, lenvatinib pembrolizumab versus chemotherapy, and it was overall survival. The problem, what we've seen in studies, and we saw this in Keynote 21, there's a higher discontinuation of pembrolizumab when given with lenvatinib than when given as a monotherapy, suggesting that the doctors are taking patients off pembro when they didn't need to, when they should just be lowering the dose of lenvatinib. Okay, so that's sort of an example of stopping a drug prematurely based on the toxicities. Just like, so you got to follow the toxicity profile carefully. You know, toxicities of all these agents, and we sometimes see ILD, which scares the hell out of me, right? Interstitial lung disease is life-threatening. Sometimes we see diarrhea, which is a little bit more tolerable. All of these patients are on thyroid drugs, which is, again, more tolerable. But I think that's where it's important, the management of toxicities, not only use your own knowledge, which is great, but to really rely on your multidisciplinary team, your nurse practitioners, your extenders, other specialties that could help manage toxicities, especially for drugs that may be working for a typical tumor.
Excellent.
Thank
Next two questions are going to be from Paula Mateo here at Houston Methodist.
Hello, thank you very much. First of all, on behalf of my colleague Mo, who couldn't join us today, I would like to ask the following. Does the immune checkpoint inhibitor-free interval concept borrowed from melanoma and lung cancer apply to endometrial cancer? Why or why not?
Yeah.
Vivek, did you have an answer for that, or you want me to take over?
Yeah, I can partially answer, and then you can actually further respond. So
Okay.
yeah.
So basically, it's a good question. The immune checkpoint free interval, we see from the anecdotal evidence from the Rose article, it makes sense with DMMR. In PMMR, it's probably going to need to be a jump start. So I think it's less about the interval, but more about what you're going to consider to add to it. DMMR patients, we talked about the WRN helicase inhibitors may play a role. There are some companies that have them under development. PMMR tumors, I know some people go from single agent, or GY018 Ruby over to lenvatinib pembrolizumab. I'm not so excited about that. Some people go to Ipi/Nivo, which I think I'm a little bit more excited about that. We learn a lot from our experience with melanoma and non-small cell lung cancers, but we also have to acknowledge we can't rely on that too much because it doesn't always carry through to endometrial cancer.
Great. So, Paula, why don't you go on to your next question, because we want to really take advantage, and we have about 3 more questions. So please proceed.
How do you see synthetic lethally treatments like drugs that inhibit the Werner helicase being incorporated into the sequence of therapies after progression on immunotherapy?
Yes.
Yeah.
Yeah, we need to do studies. I think they're an exciting drug. I think we're better at predicting with the resistance with the annual Ploide score, as mentioned earlier, but we need to look at combinations, as Vivek was alluding to. We need to look at WRN helicase inhibitors, as you're alluding to. And we need to see not only if they respond or not, but if they do respond, are they going to outperform the ADCs? Remember, ADCs, there's about 300 ADCs under development. In endometrial cancer alone, in the GOG, we've got about 10 that we're looking at. So, your question's spot on, but not only we do look at is IO after IO work, but is IO after IO going to be better than some of the other strategies that we have? The other one, I mentioned this quickly earlier, hormonal therapies in strongly ER-positive tumors, they work.
Mm-hmm.
So,
Exactly. All right. So we'll go to Mexico now. Sanidu.
Hello, thank you very much. Please,
I think Sanidu has a bad connection. His question was, what mechanism of resistance discussed in the article are most compelling, and how might they influence patient selection for rechallenge?
Vivek, you want to start with this, and I'll.
Yeah. I think the most compelling resistant mechanisms are those that clearly indicate that when rechallenge is unlikely to work, actually. Like we have already talked about the loss of antigenic presentation. So due to mutation in the P2M or JAK1/JAK/2, that turns off the tumor's ability to present the antigen, and thus the immune system cannot work on the tumor. So those are the patients, I think the tumors, because they cannot see the tumor, they are unlikely to give the benefits to the patients. The other thing is the immunosuppressive tumor microenvironment, where the high VEGF signaling and high TREG and MDSR populations actually make the tumor microenvironment more immunosuppressive. So in those cases, maybe multi-kinase inhibition or anti-VEGF combination might be beneficial in addition to the immune checkpoint blockade. And the other point I was making actually is the heterogeneity within even the dMMR population. Like the MLH1 methylated dMMR patients were less immunogenic than the Lynch-associated tumors. So, and in those patients, there is a high subclonal neoantigen. So that reduces the effective T cell recognition and also the ICI response. So, but I think the mechanism of resistance, which is less likely to be benefited the loss of antigen presentation, because the tumor cannot be seen by the immune system to act upon.
Excellent. And as a last question from our fellows, we'll go to Tommy Meschini in Italy.
Hi, thank you. Thank you for your presentation and your time. And I want to ask you, based on the available evidence and ongoing trials, do you believe that immune checkpoint inhibitor rechallenge is currently justified before proceeding with standard chemotherapy in patients who relapse after prior immunotherapy?
Yeah, I'll take that. I mean, the answer is yes, but we need to get more prospective information. The problem in these patients as they recur is we don't have good second-line therapies. The best second-line therapy we've had is pembrolizumab, and now when we move IO into the first line, it's call it active if you want, but it's less active. The chemotherapy options, weekly paclitaxel or adriamycin. Non-chemotherapy options or bevacizumab is active in endometrial cancer. People have a tendency to forget that. Hormones, as mentioned, in the ER-positive endometrial cancers are active. We have an FDA approval for trastuzumab deruxtecan in the 3+ HER2, NCCN listing in the 2+ HER2. There's I mentioned a ton of studies going on, but I understand a lot of people don't have those studies. So, I think there's a lot. We saw some activity. I think years ago, Pedro Jubilee did this Gemzar and cisplatin as a way to help overcome some of that toxicity. So we'll see. The other point I want to make, talking about IO in the second line, another way to get IO to work really well in the second line is not to give it in the first line. What do I mean by that? dMMR, it's a closed deal. dMMR tumors deserve IO in the first line. But PMR, albeit the FDA approvals and albeit the common use, we can still do better. Right, GY018, the hazard ratio is 0.64, which is the best of some of the others, but maybe we could still do better. What do I mean by that? There's GOG86P, which showed the activity in P53 mutated tumors of bevacizumab, which may be highlighted there, and there's a follow-up NRG study that's going to open up soon, looking at exactly that: carboplatin paclitaxel bev, carboplatin paclitaxel pembro, carboplatin paclitaxel bev and pembro. In addition, there's a P53 wild type strategy as a biomarker, looking at selinexor in the maintenance setting, which is a nuclear transport inhibitor. Carboplatin paclitaxel, if they have stable disease or PR or CR, they go on to get selinexor maintenance versus a placebo. The first trial on that, the SIENDO trial, albeit a negative trial, when they looked at the P53 wild type group, they had a hazard ratio of 0.44. So imagine that. Imagine, like right now we have ingrained in our heads, IO first line, IO first line. Maybe we're going to push it to the second line and look at the activity there. So, what I learned from Pedro when I was a fellow and he was my attending is we're not just trading patients one line at a time. We want to think about what they're doing later on and later on and later on. So thank you for the question.
And thank you so much, Brian. And we'll get to one last question from the audience. Can we see estrogen receptor testing in recurrent endometrial cancer previously treated by immunotherapy plus minus chemotherapy and decide on re-challenge?
So I think the question was, does estrogen receptor testing affect what you're going to use in the second line? Am I hearing that correctly, Pedro?
I think so. This is from Priyanka Singh. I don't know if yes.
Yeah, so Priyanka said yes. All right, so I'm a big believer. Pedro, you wrote an article, I think, about hormonal use in endometrial cancer. If my memory serves me right, you had our beloved friend Mike Frumovitz work with you on that years ago, I think, which was a great paper. And then when I was at Anderson, I started the work of everolimus letrozole, mTOR inhibitor with hormonal therapy. Mansour Mirza did some great work on CDK4/6 inhibitors with hormonal therapy, I should say. There's a recent paper at ESMO of a nab-sirolimus next generation mTOR inhibitor with hormonal therapy. The key with hormonal therapy, and I'm glad you brought it up, is choosing the right patients. It's not going to work for widespread disease with ascites in a symptomatic patient. It's more of a cytostatic agent. But in patients with 1 or 2 lung metastases or liver metastases or indolent course that's strongly ER positive, I think it's a great choice. For 2 reasons, it works, and it can increase a chemo-free interval. And I just earlier told you to ignore that. But when I think chemo-free interval, I think of getting the toxicities, so your bone marrow gets its strength back and things like that. So I think in all cases that if they're ER receptor positive and right selected patients, to give hormonal therapy. And then if you're going to give IO after IO in the second line, just do it in the third line, if you think it's going to work. I hope that's helpful to the question.
Excellent. Thank you so much, Vivek and Brian. We really enjoyed having this discussion. As always, learn a great deal. I'm incredibly proud to have taken some part in your mentorship. And again, thank you for all of the contributions you continue to make to the field of gynecologic oncology, particularly for women with endometrial cancer. So always very, very appreciative. I want to remind everybody the recording of today's sessions will be available in the IJGC, IGCS, and ESCO websites. And I will also like to invite you to our December Journal Club, which we will be discussing a manuscript titled The Surova Study with Luis Chiva, a global real-world treatment strategies and mortality risk prediction in advanced ovarian cancer. So thank you very, very much. I always want to thank the fellows for doing an amazing job and posing those really important, hard questions, and for your time and your presence in this journal club. Thank you.
Thanks, Pedro. Pedro, when you leave your role as editor, please keep doing these, because it's great to have learners on, and you're a leader in this area. So at least train your successor to keep doing these, because it's fun to be a part of from my perspective, but it's fun to spread the word globally, and you've been a leader at leading that effort.
Thank you so much, Brian. Thanks, everybody.
Thank you, everyone.